We're back with part two of our conversation with Jake Nichols, PharmD, MBA, author of Unfit for Recovery. If you liked the first part, this one is even better. Let's jump right back into the conversation.
Another phrase that you talked about, I believe, was dirty versus clean.
Yes.
Urine samples.
Yeah. The language that we use is very important. And I remember the first time that really became a big push in the field, and I kind of rolled my eyes going, well, how big of it, who cares? We're talking about how we talk. But to your point, again, it medicalizes things, and that is reflected back ultimately onto a patient, whether we realize it or not. And it helps to frame our attitudes towards this. And it's again, very simple things that can go a very long way.
And with that rephrasing and with the training, how has the opioid epidemic affected the pharmacy profession in your eyes, besides just those aspects?
Yeah. Wow, that's a great question. It's been a very complex effect. I think, first off, I've always firmly believed that the incidence of SUD and OUDs, particularly in our profession, is vastly underreported. And the reason that it is because A, we have access, and B, there are consequences to finding out that somebody is struggling with this. And again, I'm not taking a shot at boards of pharmacy. They have a very, very difficult task of trying to help those that are struggling with this with the risk to the public. And when you are intoxicated, obviously there is a risk to the public. And it's very hard to determine if somebody is appropriate to return to work to be able to fulfill the duties of a pharmacist. So, I think with COVID, it's been clear, as the opioid epidemic has gone on, things have worsened. They've worsened for healthcare providers in general, just due to the stress that we've dealt with over the years. So I would guarantee you that the incidence of this, people struggling, has gone up all around. That's clear, but uncharacteristically within our own profession. The other thing that it's affected, just, shifting gears a little bit, is as the focus has become on lawsuits and pharmacists and wholesalers and being accused of being a big part of the growth of the opioid epidemic, which I have very mixed feelings about, to be honest. I firmly believe a lot of this is just finger pointing and trying to see where, they can get money out of organizations and so forth. And again, we all played a role in this as a society, but I think pharmacy in general, we're in a very tough spot. And we have very limited access in most cases to patient records. And clinicians are historically confrontational when we call, especially around pain issues and addiction issues. There are privacy statutes in place that people are very fearful of violating and getting sued. So again, it puts us in a very difficult spot. And I think as a result, we've been getting dropped in the middle of this, where we're trying to balance patient care with not getting sued and not losing our license. And as a result, we see a pretty moderate rate of pharmacies choosing not to carry drugs like buprenorphine or limiting the opioids that they carry. And a lot of that is mandated by wholesalers. It's mandated by companies, and the DEA is involved to some degree. And, when you get all these guys in a room and you ask who's doing this, they all point the finger at each other. So it's a really kind of concerning thing. And I think it's caused us to back off, actually, from engaging with folks that struggle with these issues, just because of the concerns around liability. I can tell you from a more global standpoint, if I'm a chain pharmacy executive and looking at getting pharmacists more involved in SUD, and I have my wholesalers and DEA breathing down my neck around how much buprenorphine I'm dispensing, that's not going to be something that I'm going to push very hard. So I get that. So it's affected us in more ways than people think as a profession. But concurrently, I've also seen some very positive things. As the epidemic has grown, we've seen some small pilots where community pharmacists were very involved in initiating treatment with MAT and following up with patients on a regular basis. And we saw incredible rates of engagement and patient satisfaction around that. So I'm really hoping that that trend will continue, because we can certainly play a role in facilitating people getting onto treatment and connecting them with the right care, which again is probably our biggest challenge right now in the field.
I agree with your thoughts about, the liability just continuing to increase for pharmacists and pharmacies all over the country. And, people they don't want to take on more what they feel to be liability. And that's really what makes it so hard for people to access treatment, because if this was a type of cancer, that would be very unethical.
Different story.
It would be deemed very unethical to, I'm not going to, supply this kind of medication because this has liability of.
Right, exactly.
I will say I am also very happy that you mentioned the positive aspects too, and mentioning those community pharmacies that have really stepped up and helped provide for their communities, because even in the midst of everything, they're still going out there doing what pharmacists, what we all want to do, and helping the community. Just like how, for example, you mentioned COVID being hard for a lot of people, how a lot of community pharmacists stepped up then. It's very similar, just showing how pharmacists can do that.
Exactly.
And you also, with the liability, you mentioned like manufacturers maybe being worried about liability and whatnot. With the recent, the ongoing rise in fentanyl manufacturing and distribution, how do you predict that will have an effect on current and future states of the opioid crisis?
Yeah. The most distressing and, again, I think demoralizing at times aspect of working in this field is the historical side of it and how it waxes and wanes. And what I mean by that is every time it seems like we're making some progress in wrapping our arms around this, a game changer is inserted into the mix. And I'll give you a couple of examples. We had the heroin epidemic, and the 70s kind of come down in the 80s, transition more into the cocaine crack epidemic. Heroin makes a big comeback in the 90s. We wrap our arms around it, and then we get OxyContin. We wrap our arms around that, and it blossoms out into generic oxycodone 30 milligram tablets, and heroin makes a resurgence. And it's basically thinking like we kink the hose in one area and it balloons out in another. And fentanyl is the latest. In combination with methamphetamine. Methamphetamine is grown dramatically at a rate that we have not seen yet in this epidemic. It's right up behind it. But fentanyl was definitely the game changer, because it was a couple of reasons. Obviously, much more powerful than traditional opioids by magnitudes of tens to hundreds, depending on the type of fentanyl. But more importantly, and this is the piece that people are still struggling to understand, is this idea of fentanyl analogs, meaning that not all fentanyl is created the same. There are at least 30 of these floating around that have been synthesized that we know of. And think of this, every fentanyl molecule, the type is different. It can exert different effects in the body. It can bind to the receptor in a different fashion. It can take longer or shorter to be excreted. And we just don't know because we never studied these things. So what that's translated into is a couple of things from a treatment perspective. People needing multiple doses of traditional naloxone products to be revived. Clinicians claiming that it's much harder to institute MAT because of this unpredictable nature of these fentanyl analogs, especially with buprenorphine. So my point is, I think for the near future, at least in our lifetimes, all of us collectively, you're always going to see something like that, meaning they will find a way. And when I say they, I'm talking about the business of this is the cartels and other countries that are involved with this. And again, not to get too much off on a tangent, but their business models make Microsoft look like a lemonade stand. And they're always looking for the next thing. And I guarantee you, they probably have another 30 to 40 analogs of fentanyl that we haven't seen, that they haven't released yet. We have these very powerful chemicals that are similar in structure to opioids called nitazenes, which are thousands of times as potent. It's always going to be something. Where there's a demand, there'll be a supply. And when you have business models like the cartels and the politics and everything else that goes into this is going to continue for a long time. We're not going to have a solution to this. And that's why I firmly believe we need to start looking at this from more of a harm reduction perspective than we have been. By no means are we facilitating substance use, but we need to meet people where they're at and offer them safer ways to use if they're going to use, and offer them resources and connections to treatment. I really don't see any other option right now to save lives.
And you actually mentioned something that I think is really important to bring up that is often very stigmatized, which would be multiple doses of Narcan, because a lot of people don't realize that sometimes it does take more than one dose, and it's not just someone going and getting high a second time immediately afterwards.
Yeah, exactly. Yeah, it's literally taking 2 to 3 doses on average of nasal naloxone to be able to revive somebody. And that's why we're seeing higher dose naloxone formulations come. We're seeing intramuscular formulations come out with auto-injector type devices. We're going to see more of that. And in my opinion, it's needed.
I also agree, like the stigma regarding Narcan use and how many times people need to be revived. I never understood that, because if you can save a life, save a life. That's
sure.
I have some Narcan right here.
Yep. Excellent.
From my training.
We should all have it. We should all carry it. I have it in every bag that I carry around, that I travel with. It's in my car. It's everywhere.
I also like how you mentioned how we currently have this punitive system where it's let's throw people in jail and not address the underlying concepts. And you kind of briefly mentioned some things that they need to start thinking about to make sure that people are safe, knowing that this is a disease. And we have to address the fact that, okay, if you need to use, are you doing it safely? I guess an example of it in West Virginia, we have a needle exchange program, but what other concepts or ideas have you seen that have been innovative?
Yeah. As we talk about the legality of certain things and, the involvement of the legal system in general, one of the things that still baffles me is that in many states, fentanyl test strips cannot be obtained because it would be considered a felony. That to me is insane. And crazy. And states are individually decriminalizing that so people can have access to them. There's a lot of them still that have that. And again, some of it's not necessarily a stigma issue. It's just a historical issue of how we've regulated, medical products. But that's where we need to start, fentanyl products. Naloxone to me is a no-brainer. We should have naloxone everywhere. People should be carrying it. I'm a big fan of vending machines. I'm a big fan of it being available in schools. But along with that needs to be training. It's great to have it out there, but if people don't know how to use it appropriately, it's not going to help. I mean, we talk about these multiple doses of nasal naloxone. That could be due to a couple of things. People may not be waiting sufficient periods in between doses. You only get about half of the actual dose that's absorbed into the nasal mucosa. If somebody has vomited and there's, obstruction in the nose, that's going to affect absorption. A large percentage of people have nasal obstructions or deviated septums. There's just a lot that goes along with this that people don't traditionally think about. And it goes along with that with CPR. I think we're getting there, but we're still not nearly at the level that we need to be. There was a study published somewhat recently in the last year that modeled out across the country adequate naloxone capacity for each state. And 1 out of 50 states, according to this model, had an adequate system in place to be able to address overdoses on a large scale. So, we still got a long way to go. And I also see pharmacists as being pivotal, in promoting that, because we're just a great access point. So naloxone, syringe exchange programs. It's taken me a little while to get comfortable with safe injection facilities. But again, I think that's where we're at with the field. A safe injection facility is not where somebody goes and they're given drugs to inject. They do that in other countries, and there's merit in that. We could discuss that, but it's the idea is to give people safe equipment to be able to utilize their substances, to have naloxone on hand in case somebody does overdose, which obviously is a tremendous risk with fentanyl these days. But most importantly, to be able to have folks there to talk to them about treatment options. And just another touch point where we can hopefully get some people to start along that path.
I think that's a really, really good explanation. And I think that's kind of where we're heading in the next few years as people become more receptive and more progressive to these ideas.
I hope so.
I will say I'm really proud our school just recently got it to where we have naloxone in all of our dorms. So
I was really happy about that too.
Progress.
You registered for our upcoming Federal Compliance Summit on April 16th from noon to 3 p.m. In this 3-hour virtually delivered live CE event, we will have experts from the Partnership for Safe Medication and USP who will be covering everything you and your pharmacy team need to be compliant with DSCSA, USP 795, and USP 797 this coming November. We look forward to seeing you there. Register today at wvpharmacy.org.
So to kind of, speaking of our pharmacy school transitions, so I know in pharmacy school in general, we are kind of given simulated patients that are fairly straightforward and overall pretty simple. But in reality, real patients, they can be very complex and have multiple comorbidities.
Sure.
So what do you think the pharmacist's role is on the healthcare team in helping address not only treatment efficacy in regard to MAT, but also addressing each of the residual health issues?
Yeah, I think it's a huge potential role. And again, I think that starts with us understanding what the disease involves. To your point, when we're dealing, let's use opioid use disorder again as an example, that patient may have multiple behavioral and medical comorbidities, as you mentioned. And again, we don't do a great job in this field of treating the whole patient. So, as a pharmacist, being mindful of that, as we do on a lot of other healthcare teams in other disease states, we find those little pieces that were like, maybe we should address this, or maybe we should initiate this medication to, oh yeah, I didn't think of that. It's just these little things that we kind of throw out there because that's the way we're trained to think. And being able to, again, be another voice that is not just a medication expert, but a disease state expert, and being able to suggest those interventions that we know are likely to make a difference. On a community level, how can that be done? It's basically it's community relations. Know who the clinics are in your area. Know where the meetings are. Know where the resources are. Get to know the local counselors and therapists so you can refer patients. If you're going to engage a patient with SUD, you better have some resources to be able to offer them. Otherwise, it's going to be a pretty empty conversation. And in all likelihood, they may decide they don't want to take advantage of that, and that's fine. But maybe after the second or third try, they might. And that's really what it's all about. It's more just touch points with these individuals and people demonstrating that there's a lack of judgment and demonstrating empathy and showing them that, hey, I'm not here to judge you. I'm not here to chastise you, but I'm a resource to you. And again, that really goes a long way. It sounds very simple, but it's very, very powerful.
That was a really good way of explaining everything. My second question related to what we're taught from the pharmacy curriculum versus in real life. We're kind of always reminded, adherence.
Mm-hmm.
And so in this case, in what ways do you believe treatment non-adherence to MAT due to access barriers that we discussed prior negatively affects patients?
Affects them a lot. Probably affects them more than most other chronic disease states. There will be tremendous amounts of medication non-adherence. We see it all the time. It's the nature of the disease. If somebody experiences a relapse or a return to use is a better term, they're going to stop their medication because they know it's going to potentially impede their ability to experience that high or that euphoria. Obviously, that's more of an issue with naltrexone and buprenorphine than methadone, but people will revert to their original substance and leave the other one behind. Again, that's not a reason to throw somebody out of treatment. That's not a reason to chastise somebody. If we look at numbers and just look at SUD as a whole, it takes the average person at least 5 tries at a recovery to be able to maintain it long term. It's a relapsing, remitting disease. The brain takes a while to heal. Some people say at least 5 years. And that's another reason why we try to keep people on some of these medications for extended periods. There's some good evidence to support that. So there's a lot of benefits when we talk about medication adherence and why people need to take their medication. And probably the most prevalent one is it'll save your life. Again, the benefits that we've observed and we found in studies in reducing the risk of overdose and overdose death are astronomical. And getting rid of those cravings and getting people on that path to recovery. And sometimes it just takes a little bit of a reminder to do that. On the other hand, you get people like me, I never forgot to take my buprenorphine. The fear of going into opioid withdrawal kept me on that medication. It certainly wasn't getting me high and there wasn't a buzz or any pleasure, received from it. But the fear of going back to that kept me compliant. And, once you get some traction in recovery, you don't want to go backwards. You don't want to return to that. But sometimes it's inevitable. And if that happens, you pick up and you start again and you move forward.
I like the metaphor you used where you said remission. I think that is a perfect way to put it, because just as any other disease like RA, we talk about, remission. And
exactly.
These are things that we should normalize.
Yep, you bet.
And we've talked a lot about legality and just different medications, like you just mentioned, buprenorphine. And actually, recently, it was voted to no longer require prescribers to have a separate DEA X number to prescribe buprenorphine or Suboxone. So how do you see this impacting the state and potentially influencing other states moving forward?
Yeah, so this started on a federal level. So federally, they've removed the X waiver and they've removed all the requirements that go along with it. And each state basically has to decide if they're going to allow that. And it was very encouraging to hear that, West Virginia was one of the first to basically ratify that and agree with it. I have very mixed feelings about it for a couple of reasons. You see a lot of media posting about it. You see a lot of excitement around this. I'm always a glass is half full guy, but in this one, I'm erring on the side of caution. And my feeling is this: I don't think this is going to all of a sudden flood the field with buprenorphine clinicians. I think a lot of people that want to do it are already doing it. I think the fact that we're still dealing with a controlled substance and that we've had some very high profile addiction physicians rated for their buprenorphine practices is still lingering in the physician world, especially. And people don't necessarily want to go into this field. So I think it's important from a stigma standpoint that we've removed the X waiver. It never made sense to me why we had limits on prescribing buprenorphine when we had none on prescribing opioids for chronic pain. It just shows you how stigmatized addiction was. So I think if anything is to come out of it, that's a huge positive. I think it remains to be seen whether this will make a difference. You may also have people that take advantage of the fact that we no longer have patient limits. And I'm not convinced we will, we may start to see buprenorphine pill mills pop up again. These are all possibilities. But, my ultimate hope is that by removing the stigma, we will get clinicians that are in places that I deem absolutely essential to be able to do this, to start prescribing. And a great example is emergency rooms.
Those were some good points on both sides. Like, the future is just open to see what happens here.
Yeah.
That being said, what are some other barriers to accessing treatment that you feel should also be addressed by legislature?
Yeah. So again, stigma is driving most of this. I mean, we can talk about lack of access, and we can talk about, we call them buprenorphine deserts, or, the deserts related to therapists is even worse. I mean, in many places, it's just not even possible to find a clinician that can counsel or do therapy from a behavioral health standpoint. So stigma drives most of it. That's what keeps people away from treatment. One of the things that I think, again, we talk about, access points and just touch points with folks that are struggling. One of the things I've seen growth in, especially over the past few years in the face of COVID, are mobile units, literally buses that go out into the community and offer a lot of harm reduction. And some of them are actually initiating buprenorphine. We've had other ones that are initiating methadone treatment. I love that. Talk about meeting people where they're at. It doesn't get better than that. The other piece that I think is worth mentioning, because we got some news today on it, is telemedicine. And again, in the face of COVID, we loosened up the restrictions around being able to prescribe buprenorphine specifically without having to see an individual in person the first time. So telemedicine blew up for addiction treatment. We had companies that grew very, very quickly and were established during that period. And that was, again, all due to the public health emergency that was declared by the White House. And it was announced yesterday that emergency is going to expire in May, which means we don't know if folks will still be able to start buprenorphine via telemedicine. Will we have to go back to in-person visits? And this is all a result of an act long ago that was put into effect called the Ryan Haight Act, about a child who ordered some, I believe it was hydrocodone off the internet and overdosed and passed away. So I'm hoping that they will extend or legislate that buprenorphine will be able to still do that. I, again, don't know. I'm hoping the glass is half full again here, but we just don't know. I think it's going to fall on the states to be able to make that decision. And I don't think a lot of states are comfortable yet doing that. So honestly, it's a big question mark. But I think, again, Brittany, to answer the question just from a global standpoint, the more touch points we can have with individuals that are struggling with substance use, especially from a harm reduction perspective, I think the likelihood of getting somebody into a formal treatment program and keeping them there goes up.
Those were some really great points. I do know that in the early 2000s, there were many expanded efforts from substance use prevention programs like DARE that targeted PSAs towards teens and young children regarding the dangers of opioid substance use. What were some ways in which those programs failed in their prevention strategies?
Unfortunately, we're limited for time, so I can't list them all, but there are many. And I'm obviously being sarcastic here. I grew up, with DARE programs, having police officers come to our schools and discuss the dangers of substance use. And, I can very clearly remember the Nancy Reagan Just Say No campaigns and the commercials, this is your brain on drugs and all this stuff. And it's hard to evaluate the effectiveness of campaigns like that on a large. Do they really make a difference? And most people, especially in the research arm, are quick to say no because the epidemic has grown so dramatically. And again, I don't think we'll ever be able to tell. I think there is a role for that, but I think it needs to come from more of an educational aspect as opposed to a scare tactic. And I can give you one example. Educating kids around how dangerous fentanyl is great. What we're seeing some really scary trends where kids are who didn't struggle with addiction are buying one pill because a drug dealer on Snapchat connected with them and asked them if they were interested, and they bought one, and that was all was it. That was it. And we're talking 13, 14, 15-year-old kids. So I think there needs to be some education from the social media standpoint and from the dangers of fentanyl standpoint. But I think even more important than that is, and again, I'm being selfish using my own experience as an example here, is talking to kids when issues of addiction and behavioral health are widespread in the family, when they're genetically part of the family tree. I took that initiative very early on with my kids. My boys are 13 and 10. They know all about my history. They understand that it is hardwired into us and that is a risk for them. Obviously, they don't know the details being that young, but just starting with that so they can understand that is a risk, and just finding opportunities to talk about that, continuously. Tonight was a great example. My 13-year-old likes to go to the gym with me now. And we walked by a guy who just reeked of cannabis. My son knew what that smell was. And he was why would somebody do that before working out? How could they work out like that? So it's just an opportunity to have a discussion about it. And where it started was years ago when driving him to a baseball practice, he saw a guy walking down the street smoking a cigarette. He must have been 7 or 8 years old. He said, "Dad, why would somebody do that? That's gross." There's my in right there to start those conversations. So I think as parents, we need to do a better job with that. As aunts, as uncles, as siblings, it's all of our responsibility to have those conversations so people can understand what the risks are.
I agree. I think a lot of issues arise from parents that don't want to have difficult conversations with their children, but your children trust you the most because you've been around them the most.
Exactly.
And speaking of education, what opportunities are available to students who want to learn more about opioid use disorders or even advocate for better care for individuals that are struggling with OUDs themselves?
Yeah, I wish there was a clear-cut answer to that, and I'd be lying if I told you wouldn't have to do a lot of work to find them. It's not a lot of work, but you're going to have to do a little bit of digging. And the federal resources that are out there through the National Institute on Drug Abuse and through SAMHSA, the Substance Abuse and Mental Health Services Administration, are actually excellent, especially, as you're getting to the later years of your curriculum and you have more scientific and pharmacotherapeutic knowledge, reading up on certain guidelines that are out there that talk about not just treatment of the disease, but the spectrum of symptoms that are involved with this, the pathology behind it. It's really incumbent upon us as healthcare professionals to gain that knowledge because it's still not a required part of the pharmacy curriculum. It's still not a required part of a nursing curriculum or a physician curriculum for that matter, PAs, NPs. We'll get there. Unfortunately, our curriculums are crowded as it is, but the scope of this public health issue it's still baffling to me that this hasn't become a standard education in every healthcare practice. From the other aspect, I think we're doing a better job as a profession in offering educational opportunities around this. Certain states like West Virginia do a better job at it than others, and I think a product of that is partially the severity of which the epidemic has affected you guys. You're living in ground zero, as most people like to say. And you've also got a lot of great people there doing some incredible work. So learn from those people, meet them, talk to them. You guys alluded to the SUD Institute from the American Pharmacists Association. We host that every year in late May, early June in Salt Lake City, Utah. You will not get a better experience than sitting through those few days and not just learning about the ins and outs of the disease, but experiencing what it's like to sit through a 12-step meeting, and be able to have the opportunity to share some of your own, experiences in a very safe space. You got to seek them out, but they're out there.
The Institute on Substance Use Disorders was a very great experience. I really enjoyed my time there. It was nice being in Salt Lake City too.
I agree that is a really great program for students and also non-pharmacy students as well. Yeah. It's very educational. And I think that's a great point about the pharmacy curriculum. It has not been updated well enough. There's a bunch of symptoms that people, don't really fully analyze because they don't associate with stereotypes. Right. And so they just miss the important clinical signs.
Yeah. And I think the encouraging part of it is any school that I know that has an elective that they offer an addiction, it's usually booked as soon as it's available. People really there's a thirst for this education that's out there. And I think it's incumbent upon the schools and ACPE and professional organizations to be able to provide those opportunities.
on top of that, what are some ways that pharmacists and interns can work on creating a safe environment in the pharmacy setting to allow for patients to feel comfortable sharing their experience?
It takes a while. It's not something that can happen quickly. And the reason I say that is because when folks are struggling with SUD, they're expecting to be judged. There's the toxic shame that goes along with it. And they're especially worried about that with healthcare providers because they almost feel like they've let them down to some degree. You know, they're experiencing something that they've been warned against, that everybody knows about. It almost feels like you're a failure to some degree. And being able to express to them that that's not the case can open the door to a great therapeutic and sometimes personal relationship. And the way I tell pharmacists, students, anybody that's interacting with these folks to initiate the conversation is to be honest. And regardless of where you're at in your career, play the student. And I can give you an example. If you're encountering somebody who you think is struggling and may need help, let's say somebody comes in to pick up a prescription for buprenorphine. One of my favorite things to do when I'm giving a talk with pharmacists is to ask how many are comfortable counseling a patient on the use of buprenorphine. And you may get a third of folks raise their hand, and probably a third of those people are lying, but they just want to look like they're good. But it's not something you look forward to because you're like, how do I broach this topic? I don't want to sound accusatory. I don't want to sound confrontational. I don't want the patient to feel uncomfortable. So I tell people to be honest about that. Say, look, I personally don't have any experience with this. We're taught very little about it in pharmacy school, but I want you to know that I'm here as a resource for whatever you need me to be. If you need help with your medication, if you're having any problems, or if there's any resources I can connect you with, just let me know. Whatever I can do to help you in your recovery, I'm here. And leave it at that. It sounds very simplistic. It sounds very basic. Some patients may actually faint when you tell them that because they're just not expecting that. And some people honestly may say a couple of rude words to you and walk away. But I guarantee you the majority of them at some point will want to engage with you because it's just one more person that they feel like is not judging them. That's a resource for them. And I tell people not to underestimate how powerful that is in the early stages of somebody's recovery. And I look back and I was just very lucky to have the right people in my life at the right time that encouraged me with usually very simple words along the way. And that makes a huge difference. So it's creating a culture, like you said, within the pharmacy. If you're encountering preceptors or peers that seem to have issues with this disease state or don't want to interact with these patients, try to dig into why that is. You want to tread lightly if there are personal issues behind that, obviously, but most of the time it's a lack of education, and a simple conversation could start like, do you actually believe it's a disease? And if somebody says no, you're now equipped to explain to them why it is. And people will see, okay, all right, I get that. Because again, especially that older generation, the stigma and the lack of education is driving most of this.
I 100% agree. I think leaning into that uncomfortable feeling for people is that's where the true understanding comes from. And so with all of this, I'm so grateful to have you on the podcast. And I'm sad this is our last question. But my last question for you today is, how do you think pharmacy practice will expand to encompass more patient-centered care regarding opioid use disorder in the next 10 to 15 years?
Yeah, great question. I firmly believe there's going to be significant growth in our involvement with this disease state. I think it's kind of twofold. I think we're starting to generate some data as a profession that shows that we are more than capable of a lot of things that people don't necessarily think of. And to get mentioned in a journal like the New England Journal of Medicine recently about a community pharmacy program where we're initiating folks on buprenorphine tells me that we're moving down the right path. That's a very big deal. And that's probably the third or fourth one we've had that's shown that. And again, as it really starts to come to light, especially with the removal of the X waiver, that we need more access points for folks to start engaging. I think we will be turned to as a profession to be able to provide that. maybe under collaborative practice agreements, but so be it. To me, that doesn't matter. It's just a matter of let's do what's right for the patient and offer them those resources. The other thing that I think that goes with that is, as technology has grown and remote verification has grown, and we're starting to see cutback on hours for pharmacy. That's been the big buzz in the field for the past week. It's showing that the profession is evolving. And again, our clinical expertise is really starting to come to light as more of the technical functions of what we like to refer to as the lick, stick, and pour are being done more efficiently. So I think it's all moving in the right direction. In 10 to 15 years, I see the pharmacy as being just an extension of a clinic. I really see the model. All pharmacies to me will have a healthcare provider in it, and that hopefully will be us. We are obviously healthcare providers, but I think on a clinical level and a provider status level, I think we'll be there by then. And I think we'll fall into that advanced practitioner role where we'll be able to bill for these services and specialize more in treatment, especially as it relates to medication use, which is obviously our expertise. So I'm probably more encouraged now than I ever have been. When I was going through pharmacy school and we just transitioned over to the PharmD as the standard degree, all this stuff was new. And I try to tell myself that wasn't that long ago, but it was. But just the growth that I've seen in the past 5 years, I think vaccinations help that. I think some other pilot programs help that. We're clearly have a big role to play in all of this, and we've been underutilized for so long.
I firmly agree with that. I am excited to see hopefully those things occur in the next 10, 15 years. I definitely see that push forward towards provider status at a federal level and kind of that expansion of pharmacy practices. And so with that, I wanted to leave the floor open for you to express any last minute thoughts.
Yeah, no, again, I appreciate you guys having me. It was an absolute honor and it was a great discussion. I really appreciate your questions. Very insightful. If I could encourage folks to do one thing, it's to talk to people. A lot of people are struggling with this. We all know somebody. If you don't feel comfortable talking it, it's time for some self-examination to figure out why. Is it a lack of education, or is it pain that you're carrying around from an experience that you've had? And there's really no reason for us to carry around that pain. Everybody has their struggles, and we need to destigmatize just talking about that and getting help when we need it. So appreciate everything that everybody does. And again, I'm really looking forward to see where our profession goes over the next 5 to 10 years.
We all know someone who may be struggling with substance use disorder. The conversations can be difficult, but are so necessary to begin the healing. As a reminder, West Virginia is fortunate to have a pharmacist recovery network, which helps pharmacy personnel who may be impaired by medications, alcohol, or psychiatric disorders. You can enroll or report someone you may be concerned about confidentially who needs help at wvprn.com. Additionally, our partner in service, the West Virginia Drug Intervention Institute, is always available to provide information and connect you to resources to help. Much like our WVPA motto, we are stronger together, and with that strength, we can do so much to help those struggling with substance use problems. Mountain State Pharmacists is a product of the West Virginia Pharmacists Association.